Right, the first one's from Lynette. My husband had a heart attack and SCA without having had any symptoms, so the event was completely out of the blue. How do we know his heart, which has now had one stent fitted, is working correctly? I am worried for the future in case the same thing happens again.
Okay, so I guess there are a number of positives I would say here. I think at least we know why he had the cardiac arrest. I think for a lot of people that can be extremely helpful. And in essence, what we know happened is almost certainly an artery blocked. The blocked artery meant that the heart muscle didn't get enough blood supply. The heart muscle then says, I don't like this very much. And it goes into a crazy electrical rhythm. And that crazy electrical rhythm obviously means that you fall to the floor and lose output and requires defibrillation, as we know from a defibrillator, to make it better. And then, of course, the problem needs fixing, which by the sounds of it, he went to a cardiac centre and got a stent, which is great. So I think the easiest way to reassure you with regards to that is that now he's on all of the right tablets to prevent this happening again. The event rates are actually really pretty low because he's on all of the right medicines to prevent it. Obviously, the stent will keep the artery open that caused the problem in the first place. And the ambition would be that now on all the right medicines controlling his cholesterol, his blood pressure, the blood thinners that he's on, that he won't run into further problems. And from my experience, I've never seen someone with a heart attack and cardiac arrest go on and have a second cardiac arrest. So that doesn't mean it can't happen, but I would just reassure you to say I think it would be fleetingly rare. Of course, all of us can go on and have other heart attacks, but it's incredibly unusual and unlikely that he'll have another cardiac arrest, I would say. Not impossible, but very unlikely. The next most important thing for everybody out there who's had a cardiac arrest is their heart function. So if your heart function is good, again, especially after a heart attack, that puts you into a good group that generally will have not too much in the way of symptoms, and that your heart function, the better it is, the less troubles you run into in the future. So I think hopefully I've kind of outlined why heart attacks, at least you know the answer. And secondly, if your heart function is good, and what that means realistically in percentage terms is greater than 45 or 50, above 55 is completely normal, and less than 30 would suggest the heart pump is not so good. So I hope that answers your question.
I've got a follow-up there, just to say, you said that on people who have had remedial action done after an initial heart attack, it's unlikely for them to have another cardiac arrest. Why would that be?
So two reasons. Number one, predominantly the medicines. So, as you know, beta blocker, of which most people after a heart attack will be on, is a very, very powerful antiarrhythmic. So even if, God forbid, you were to have another heart attack, which we know is very unlikely when you're on a good dose of statin, aspirin, your extra blood thinner, your blood pressure well controlled, the beta blocker will generally prevent the arrhythmia very, very effectively. So you've got much less chance of having a further heart attack, and then you're on medicines to prevent cardiac arrest. So I think that's why you're on the tablets you're on. It's to protect you from further heart attack and protect you from further arrhythmia.
As part of that, thank you, Tom. As part of that question, the partner who was asking it was saying that they were concerned or worried about for the future it happening again. And going on to the follow-up question, what would you suggest are some of the best, most empowering ways to help survivors and their families come to terms with the fact that they have had an event like this and come back from death, as it were? That's to both you and to Marco.
Yeah, I think Marco might be better at answering that, but I understand if he wants me to have a stab. Either way, I don't mind.
If you've got something to say, please go ahead, and then I'll try and give my answer.
Well, I mean, all I was going to say is certainly what me and Marco and I have seen over the years of following up cardiac arrest survivors is that everybody is different. And I think that is the key thing. And it's different from every perspective. So every patient that has a cardiac arrest will have a different baseline status. Some people will be incredibly fit marathon runners who have never been to a hospital or seen a doctor in their lives. Other people will be older with more problems, diabetes, kidney problems, etc. And their baseline will be very different. So you can imagine that their health status before it happens is very variable, and therefore the way in which they react to that cardiac arrest can be very different because they start from a very different baseline. There's then all of the issues with regards to the cardiac arrest itself. What is the cause of the cardiac arrest? And again, I find generally, and I don't know what Marco thinks, that if you have a heart attack and everyone knows exactly what the cause is, people generally can come to terms with it a little better than when we tell you, oh, it's idiopathic, we have no idea what caused it. It could be anything. You could have a channelopathy, you could have an unusual cardiomyopathy. I don't know. And I think I don't know is a problem for patients, and I don't blame you for not liking an I don't know. Then I think it depends where you have your cardiac arrest. So if you have it at home and your family do CPR and save you and do all of the things at home, then there's a huge burden for that family interaction, which if it happens at a football stadium and your family aren't there, again, the dynamics of that relationship might be different. People who live on their own versus people with a family, people with young children or children that are around. I think there are so many factors that we don't truly understand that affect the whole environment as to how you were before, how you were during, and how you are after. I think there's no set plan. You can't sort of predict a passage of how everyone's going to behave. And I think that's why Michael and I find it so fascinating, is that everyone is completely different and everyone wants something slightly different and needs something slightly different. And the only way we can look after you guys is to offer really fairly bespoke care with options. And that's what, as you know, we try and do. But yeah, it never ceases to amaze me, the variability that we see. Some people, it can be very rarely the best thing that's ever happened to them. And I've only ever had 2 patients that have said that, but we've had 2 that it's changed their life in such a positive way, it's unrecognizable. Of course, the vast majority have challenges because of coming to terms with a difficult event, and let's not pretend otherwise. So I think it's the heterogeneity, the variability in so many factors, even down to, not being funny, the amount of brain injury that someone has, or the amount of heart function they have afterwards, and the breathlessness and the tablets and the relationships with their family and friends. I think it's an incredibly complicated interaction of many, many things, which means it's very hard to predict how anybody is going to behave. And as we also know, you may do really, really well for the first 6 to 12 months, and then you may hit a problem, whether it's a flashback from something, or just something triggers something, or there's another death in the family, or someone becomes ill, or you have to go to hospital, or it's so complicated that. And I think you just need to go through your own journey with your family and friends as best you can, with the best support you can from medical people. Understand when you've got a problem and seek help when you've got a problem, and communicate. I think communication between you and your family members and people around you is uber important, rather than we tend to bottle it up and don't want to sort of worry each other about it. Whereas what we often see is the survivor is worried about the family, and the family is worried about the survivor, but none of them are talking to one another about their concerns, and that can be trouble. So I've waffled enough. Marco, what's your take?
Yeah, you have the gift of the gab. It's an incredibly broad question, and obviously, I mean, as I look at the screen now, there's 25 people, so excluding the 3 of us sharing this. There's people from all walks of life, and it can affect people in a different way. Depending on your age, depending on your background, depending on the type and circumstances of your cardiac arrest and of your recovery as well. It depends as well whether we are talking about the person who has suffered the cardiac arrest, or the person who either was there to assist them and to resuscitate them, or a family member. And it depends at what stage we're talking about. So obviously there will be people that will kind of fly through all of this without any problems. And there are possibly quite a lot of people like that, because we do offer support to everyone, and not everyone needs support. But then there's people that, I are affected in many different ways. So for someone, it might be similar to somebody that suffers a heart attack, the first sign that they're not invincible. So it's not so much having survived and having come back from death. It's just about, oh, well, I'm not as strong as I thought I would be. My body actually is not invincible. So for some people, that might be what they need to come to terms with. For say, the family member, it might be about what do I do in the early stages to support my other half, for instance, or my mother or my father. And that might be quite challenging for them as well, in addition to having to look after themselves, which unfortunately doesn't take precedence in the beginning, although in the long run it can be quite demanding. And then it's the time frame, because if we're talking about the first few weeks, few months, I mean, just recently I spoke to somebody. I mean, we do follow up people for various reasons, clinically and for research. And it's not uncommon for me to hear, oh, in the first 18 months, I was sort of okay, but not quite myself. And now that I look back, I see that, yeah, it's been quite a journey. So sometimes some things you just look back and realize. So we need to look at the whole picture, and it's different for everyone. It doesn't affect everyone in the same way. Obviously, some people are not really badly affected. Some are. Sometimes it's a survivor, sometimes it's family member, sometimes it's both, and sometimes it's not the beginning, but it's the end, or it's the other way around. So I think it's incredibly varied, and we know that there's different needs at different points in time. So I always keep an open mind and think about what's the issue here, because for some people it might be really that not being invulnerable, that feeling of unpredictability. It's happened once, is it going to happen again? And sometimes it's about providing information, and that helps, but sometimes that doesn't really always help. There's always the niggling feeling. I do keep an open mind, but everyone is different. It's worth sometimes having a chat about what is it that is worrying you, if it is really worrying you.
Can I just check back in, actually, Paul?
Yeah, sure.
It's interesting, actually, because when we first set up the care clinic to follow patients up, I was adamant that we need to follow people up early, because in my opinion, that was when I thought all the problems were. And completely the opposite. Marco felt that the follow-up should be longer term, and that actually at the acute phases, people would be coping, adrenaline, etc. And actually later down the line, they'd run into problems. And actually what we realize is that we're both right. There are patients who absolutely need early help, and there are patients who absolutely need this sort of acclimatization help further down the line. And so actually, of course, they now get both. But it's just fascinating that we both came at it from a completely different sort of perspective at the start, and yet we now know what the answer is, because when we started, we didn't know what so much the answer was. And we've learned over time that you need a potential support from start to finish.
Okay, cool. Following on from that, one parent, Alicia, has got a concern about her 19-year-old son who had his cardiac arrest 3 years ago, and she feels like he's come to, or struggling to come to terms with it, and that he feels like he or she believes that he felt he had died and may still feel like he's in some kind of parallel universe. Is that common? And just to say from my own point of view, when you look back on it, it just seems such a freakish thing to happen, especially probably for someone so young. And also, as I felt I was so fit at the time that I used to eat healthily and not drink that much, do all the right things. Did this really happen to me?
It's a tricky question, isn't it? Because it's obviously it's a mother talking about the son, and if this was asked to me clinically, I would obviously want to talk to the son if the son was keen to do that, because obviously we've got the perspective of someone, and I don't really know what's going on, and I would like to know, actually, because it might be that there's something. But I don't know. So that's the question. With regard to this feeling of sort of depersonalization, which is what I would call this feeling of being in a different universe, so being sort of outside your own person, I think that's what most people feel initially, but we're talking about probably weeks, maybe, shouldn't be longer than that. But then again, I would like to talk to the person, to the adult in question, and try and find out a bit more. But that feeling should really only last for a few weeks, if it's what I'm thinking it is. So I understand perfectly the concern, and it's not uncommon to have parents coming with concerns, and then it's about where do we go from here? I mean, is this something that the person wants to explore or not?
Okay, cool. Thank you, Mark.
The other thing I was going to say is that having got a teenager son myself, and maybe lots of you on the call also have teenager sons, teenagers they have difficult times as it is if you don't have a cardiac arrest. If you then, not being funny, chuck a cardiac arrest on top of being a teenager, it must be pretty tough, to be perfectly frank with you. I completely agree with Mark. I think the key thing here is communication and allowing the 19-year-old boy to speak to somebody if he wants to, who can explore this with him. Because, you know, if someone dies, we're very good at offering potentially, you know, therapies to deal with death. I think we're less evolved and less elegant at dealing with this more nuanced kind of aborted sudden death, or, you know, whatever you want to call it. And you can imagine that with a teenager who's got a lot of hormones and stuff going on anyway, it's going to be a challenging time. So I think we just need to acknowledge that and potentially offer him the opportunity to talk it through and you know, and try and come out the other side. It's because otherwise it probably is going to have some impact upon his psyche long term, and maybe if you can talk about it earlier rather than later, you can develop mechanisms for dealing with those thoughts and maybe hopefully deal with it longer term in a more positive way and in a better way, because you can imagine it must be very challenging.
Okay, following on from that, which, you know, I guess my thoughts about why I could have gone in a parallel universe or been abducted by aliens is because I had no memory of what actually happened at that time. We got a couple of questions on that theme. So this one's from Anthony. I remember everything prior to and after my SCA, although not the time I was down. This did cause me some difficulty once I had regained my physical fitness. I often wish I had no memory of it all. I've seen that many others have no recollection whatsoever of what happened. How unusual is it for a person to remember all of the events that took place on that day?
Wow. Well, I wish I could answer this question, actually. And I've always been interested in the fact that some people, I mean, I think it's not that unusual, to be fair, just to answer this question directly. And I would like to know what it means when people have, for instance, what we call retrograde amnesia. So you forget things that have happened before the cardiac arrest or any other possible injury or insult to the brain. Sometimes people forget a week, sometimes an hour, sometimes a month. I mean, the longer it is, the more likely it is that the brain has taken quite a hit. But then again, I've seen people who have forgotten the first, you know, the week or 2 weeks before the cardiac arrest, or even longer. They've made a fantastic recovery, and sometimes they remember up to the point of the cardiac arrest. And again, they've made usually a very good recovery. It's really difficult to know what that means, because I wish it had been studied more, and I would like to study this more, because I do have an interest in this. But I don't think it is unusual to remember up to the point and then after. Although usually there is a little bit of a gap. But you know, the quicker you've been resuscitated, and the more likely it is that you remember pretty much up to the point of the cardiac arrest, of 30 minutes before, 20 minutes before. It's not that unusual, in my experience. Tom, I mean, if you...
Yeah, no, I agree with you.
I do ask this question every time, because I
you probably know a lot more than I do. I think there's some fascinating work. I don't know if you think it's fascinating, Marco. Sam Parnia's work. I felt. Have you read his work? Or do you think it's a bit of nonsense? I mean, the jury is slightly out as to whether they think. Paul, you've listened to his talk, haven't you, Sam Parnia? He's a slightly energetic American chap. I think I can't remember what his background is.
He's British.
Is he?
Yeah, from Southampton. He's gone to America, though.
I was going to say, he's got an American accent. I used to think that the whole near-death experience thing was sort of a little bit, I don't know, really. I don't know. I've never had one, so I don't know. But he talks about it in a very scientific way, which I think is probably the right way to go about it, and has carried out studies that during cardiac arrests, they have put sounds and pictures on top of the line of vision of where someone might be able to see, to understand if during cardiac arrest people can still see and remember signs and sights because of this sort of near-death experience. So I think there is some research out there about it, but I think it is few and far between. And I think it is an area. My slight question to this is, what can we do about it? Does that make sense? That's I'm rather clinically directed about how can I make things better? How can I make survival better? How can I make life better? But this would obviously add extra understanding to patients for exactly the reasons that you suggest. But so yeah, look up Sam Parnia. He would be an interesting guy to have on an evening call, actually, Paul.
I suspect he's different to sort of directly the memory type question. He's beyond memory. Is it?
It's all linked, though, isn't it? I mean, memory and brain function. What you see and hear and process, and what you remember are kind of integrally linked, aren't they?
Mm-hmm. Mm-hmm.
I guess the other thing is some members of your group may find it a little difficult to talk about, to listen to and to engage with, because it is pretty kind of, it will definitely bring back memories or whatever of discussions about a difficult time. So you'd have to have people who are prepared to sort of listen to those types of discussions. But for those that are interested, I think it's fascinating. For those who'd rather leave it alone.
As a general comment, in traumatic brain injury, when you are hit by a car or you have an accident and you hit your head, it's very, very commonplace to measure the duration of what we call post-traumatic amnesia or coma, or both actually. So whether you are in a coma and when you wake up, for how long you are confused, because these are predictors of recovery. But not perfect predictors, but they are predictors. But we don't do that in cardiac arrest. And I wonder whether we should just have a look at this, because it's quite an interesting thing. And obviously there's a lot of research in traumatic brain injury about people that don't quite remember what's happened around the time of the injury. Then do they want to go back and find information about this? And there's quite a lot to draw on. So I think that's an area that needs to be investigated and developed, because for some people, weeks have been lost. And yeah, that must have an effect for someone, even if it's just a day or 2 days. So I think there's a lot that can be done there.
That neatly dovetails into my next question from Mark, who's on the call. I cannot remember anything about my event from 2 days prior until about 2 weeks post-discharge. I found myself to be driven to learn every detail of what happened, almost to the point of paranoia. Who did what, when, how, etc., to fully understand what happened to me. Would this be considered normal behaviour, or perhaps a consequence of my diagnosed PTSD?
Oh, what is normal behaviour? Consequence. I think, in this sense, PTSD is when you, it's complex, isn't it? Because what are you, PTSD is when you witnessed or lived through a life-threatening event. And obviously you can have PTSD even if you don't remember the event, as we have learned over the years, but it develops in a different way, perhaps. Sometimes people have memories of ITU and of nightmares they've had in ITU, especially if they recovered from a coma, but they were under sedation. And then you've got clear memories, although they may be false memories that you develop fear of, and then for some other people, PTSD has different and more pronounced component into, for instance, guilt. So it's a I don't know question sort of answer. It depends on how you live, how you experience this. I would say that in itself, it's not abnormal behavior trying to find out what's happened. Whether it's obsessive or not, I think it really depends on how you experience it and whether it's causing problems with other people, because obviously if that's all you talk about, it may not be functionally working for you. It is tricky. Just listening to this, I don't think there's anything abnormal, but if it's kind of 6-hour-a-day type of endeavor every day of your life, then obviously there's something there that keeps ticking and it's not moving forward. But I can only make general comments based on general questions, and in itself, it's not necessarily abnormal behavior. Everyone, I think, wants to know what's happened. Some people more than others. And sometimes for a long period of time, there remains this desire to learn what's happened. I just wish I knew.
I was going to add to that. I mean, Paul, a lot of your group have often, you included, I think, have often been helped by meeting the rescuers, meeting the ambulance crew. Very, very difficult interactions, because maybe it brings stuff back for you and your family, but maybe allows you to kind of put the pieces together, move on, and feel like you've kind of closed that bit off a little bit more, rather than if you never do that, it might always be a bit open, if that makes sense, and come back and kind of haunt you. I think the other thing we must remember is that Marco's done some lovely work, essentially assessing patients on a consecutive basis to find out how much cognitive issues that people on our wards have. And the bottom line is that, as you could expect, lots of patients who have cardiac arrest, around, Marco, tell me if I'm wrong, but around about 50% have mild or moderate cognitive problems.
It depends when you measure it. So if you ask people just before discharge, I mean, many survivors are, I would say, more than 50%. There's an element of some mild memory problems, perhaps, or more consistent. So I think time is what matters. So if you ask the same questions a week after, a good percentage of people would have done a lot better, would have recovered. And if you ask it, 6 months later, it will be even better. So I think it's important to remember that at the point of going home, usually there's still something going on, and you're definitely not 100% right. Some people are, but it's a minority. I would say it's probably a quarter that are, at least from a cognitive, thinking skill.
My point was, Marco, that you can imagine, from what you've just said and what we see on the wards, it's how could you expect to have a normal memory of the sort of 2 weeks before if you half the time can't remember what you had for lunch that day? No, seriously, on the ward. And it does take time. And I find that when people go home and get back to their own home and their own families, or wherever that sort of hospital discharge is, that's when we potentially see an improvement in patients' general sort of abilities, because again, hospitals are a difficult place to be some of the time, with not a lot of sleep, not great food, not access to your family, etc., etc. So I was just trying to normalize the fact that the brain doesn't work normally, often for a few days or even weeks in a number of patients. So don't be surprised that you don't remember bits, because if you're not functioning well, then it's not surprising.
And sometimes it works in a memory in a way that actually defies what I've seen before in my experience working with people who have had a brain injury. So for instance, I may ask you to remember something during an assessment in hospital, and you may remember after 20 minutes. I might come back the day after, you might not recognize me, which is bizarre. So, I mean, obviously the brain initially may be a bit all over the place, but this should get better. And obviously during that period in which it is all over the place, it's not making new memories consistently. It's not working well. So that's why in ITU, for instance, we and other teams use ICU diaries as well. Actually, I don't know whether we have started doing it consistently, but sometimes we just, I don't think we have actually. But Tom, correct me if I'm wrong, because I know that this is a long-term project. It's just about supporting people to know what's happened while you were there. And yeah, it's proven to work also to alleviate symptoms of PTSD for people that do develop it as a consequence, for instance, of nightmares in ICU and things like that.
Okay, thanks, Marco. I'd just like to add for those who've got memory-related questions, that you might want to check out the podcast I did with Professor Barbara Wilson, who's one of the sort of country's experts on it. If you look at the Life After Cardiac Arrest podcast, I think it's about roughly halfway through the ones I've done, and that's very good. And it explains about the different types of memory and why you sometimes lose it and things like that. Okay, Marco touched on PTSD, and we've got a set of questions on PTSD, and the first one's from Sue, who's on the call. This week, a friend's dad had an SCA at home and sadly didn't survive. It's been 10 years since mine, and I have made a good recovery, and largely the overwhelming emotional feelings I had in the beginning have gone. I was never offered or had any counselling, but I didn't think I need any. If I did get low, it passed quickly and didn't interfere with my life. However, this has hit me like a ton of bricks. I have heard of survivors' guilt and PTSD and would be interested in knowing a little bit more about this, especially the guilt aspect of survivorship.
Yeah, I think I did briefly mention guilt before. I mean, it is an element of PTSD, although not everyone experiences it, and not every type of survivor's guilt is associated to PTSD. So the two things can be independent. I mean, survivor's guilt is when you're feeling guilty, although there's no rational reason for you to do that. And yeah, it can be quite disabling, but it depends whether it's sort of fleeting or very time limited sort of feeling, and then you carry on, and then it might come back when something like this happens, because it's a powerful reminder. It almost brings you back to that, and you think about, wow, I did survive, but this person didn't, and perhaps I was in a more difficult situation. I mean, if it becomes an issue, it can be treated, obviously. So there's this. I mean, probably the first approach and first point of call would be sort of cognitive behavioral approach to survivor's guilt, where you basically kind of reason with the therapist around why you're feeling guilty, if there's any rational reason, and you have a sort of thought record sheet where you think about what the evidence that this is your fault and the evidence against it, and then you rate pre and post how you feel, pretty much. I mean, that it's much more nuanced, but it's about kind of taking stock of what's the reality and what you're feeling about it. Sometimes you need to go a little bit deeper and try and find out why it's affected you particularly, because everyone is susceptible potentially, but some people more than others in certain situations, for instance. And then there's just some other approaches around perhaps developing more self-compassion, which is kind of important when we're talking about psychological care. Perhaps also psychological flexibility, just to accept that things can be seen and experienced in a different way. But it just depends on how badly it affects the person. But yeah, it can go along with PTSD. It can be something independent, and if it's not affecting life too much, then it's just one of those powerful feelings that can come and go, but it's not necessarily abnormal, although I don't like this word.
Paul, if I could just be a little sort of a bit additive to all of what Marco said. Clearly, I'm not an expert in PTSD, but if I was just to take a slightly more generic global look at mental health over the last 18 months in itself, I think we've all had difficulties with mental health, and COVID has made everything very, very difficult, whether it's traveling, which was what we used to do to kind of relax ourselves, or just meeting up with friends and family. It's been a funny old 18 months. And I think that your access to mental health support has been challenging. It's all been virtual. It's not been in person. All of the things that maybe we relied on for many, many years to support our mental health have disappeared or become much more difficult. So I think it's not entirely surprising that with these particular challenging mental health problems and difficulties following cardiac arrest for survivors and families, it's been kind of compounded over the last 18 months. And maybe hopefully we can start seeing people again easier. We can start getting services back towards normality, seeing people again after their cardiac arrest. We have face-to-face clinics now, because we mustn't abandon face-to-face stuff, because it is really, really important, and we just need to sort of add to it with virtual stuff as and when it's appropriate and get this sort of hybrid mix. I think there's too much of that virtual is the way forward for everything, and it simply isn't. You cannot beat face-to-face personal human interaction on a variety of levels to just do a better job of healthcare in any guise. So I think we must always remember that. So I think if you guys out there have had a bit of a tough time for 18 months, it's not surprising. You know, a lot of us have had a tough time too, but hopefully we can start to see, you know, with a bit of luck, as things move on, some more normalization of social, you know, normals and getting back to seeing people in groups and meeting again together, so that we can hopefully get out the other side of that. That was just a sort of overarching thought.
One thing I would just like to say is, it's following on from the event in the summer with the Euro 2020, when Christian Eriksen had his cardiac arrest on live on TV. I think, you know, I think you'd be hard pressed to find anyone who was not distressed by that situation. So how do you know if it's just a distressing situation that's a normal human reaction, or something that is PTSD?
If there's a question,
it's definitely for you, Marco, as well. Definitely for you.
Well, if it's no, if I guess that there's a time. I mean, there's time limits for diagnosis, but I guess if it's been going on for several weeks / months, and is causing a significant distress and loss of functioning day-to-day life, then I mean that's a technical answer if you want. But I mean, if it's causing you a lot of problems and it's been going on for a long time, then it's worth addressing. That's my take on it.
I mean, can PTSD, following on from that, I mean, Sue mentioned that her cardiac arrest was 10 years ago, and Charlotte put in a comment about how she's feeling quite traumatized at the moment, and hers is 3 years, I think it was, or 3 years and 10 months, almost 4 years ago. Does PTSD have a regular time frame, or can it appear anytime, or does it appear due to triggers?
But I don't think it's, I mean, I would like to know, because in terms of being kind of mentally, having developing a mental health condition as a result of cardiac arrest, it's obviously not just PTSD. I mean, it's sometimes associated with depression or with kind of severe anxiety that is above and beyond, you know, just the reminder of the episode. So there might be just some more generic anxieties. I mean, yeah, there's no specific time frame, so it can happen and it can develop even later in time, although it tends to develop quite close to the event, but not necessarily. So, you know, if you're not feeling well, I think the bottom line is that whenever you think it is worth addressing, it is worth addressing. So it doesn't matter if it was 10 years ago, because if the problem you're experiencing is here and now, and even if you're not quite sure what it is, and even if it's not 100% linked to that event might have been the trigger. So, or it might have been such a big trigger that in itself caused the problem. It is always worth looking into it. Yeah, don't just suffer in silence.
I guess the other problem is, currently within the NHS there is a big lack of, don't like to use words big and lack, but there is a lack of skilled personnel like you. I mean, Marco, I think, is pretty much the only clinical psychologist in Essex. In London, no. Oh, there's not many. No, but there is a distinct lack per capita, and there is massive variability. So London has more than Essex. I think that's a fair comment, isn't it, Marco?
Yeah, but it's not just psychologists, there's psychological therapists as well. But I mean, if you ask me, are there enough? No, probably there aren't enough. No.
So I'm just saying, there's a provision in the UK in general terms is not adequate. And I think, you know, if you have got serious mental health problems, for me, I think the NHS currently, unless you're lucky, gives you a bit of a rough deal with what you have access to, is my personal experience. But, you know, yeah, you've got to seek help. You've got to see what's out there and hope that in your locality there are people that can support you and give you the therapies that you need, I guess.
You're on mute, Paul.
Can't believe he's still gone for that one. Can you?
So a couple more questions on the PTSD, and I'm just wary of the time.
Can I say one more thing, actually, Paul? So I know I'm not shy to talk. I think Marco made a really, really good point that we often think things are PTSD, but that is a medical diagnosis by someone who knows a lot about it, and there will be clear criteria for that. You know, there is a lot of anxiety. Inevitably, there is anxiety linked to depression. There are other things. You know, there is lots of things that play into this, and so I think he's right to say, if it's bothering you now, it doesn't matter if it's 10 years or 1 year. Go and get some support, go and get a diagnosis, and then potentially go and get the right help that can make it better. Does that make sense? So I think it's not just PTSD. There's a load of wrapped up.
My experience is that anxiety is actually more common, and sometimes it's mild, and sometimes it's quite significant, and sometimes it's anxiety for the person that lives with the survivor. Sometimes it can be, I don't want to go out on my own because I'm afraid of what might happen, or it might be anxieties around having an ICD, or anxieties around not having an ICD, anxieties around lifting up your arm and painting the ceiling. I mean, I think I've heard all sorts, and I think usually people are able to cope with this, but it does cause a little bit of distress. It does make you kind of modify what you do in day-to-day life. I guess it's a matter of how much you're modifying your life, whether it's okay or it's not okay, and that's for you to judge. I mean, so it's for you to decide, is this a problem for me or not? So it's not just PTSD, but it's all these things.
Okay. You both sort of mentioned getting the help. What is that help? Because Stephen and Dawn are both sort of related to their questions to anxiety, in particular when they're asleep. So Dawn's having nightmares, and Stephen's is related to the fact that he had his cardiac arrest soon after a transplant, and he's not actually worried about having any further operations or procedures, but it's the sort of hallucinations or the nightmares that feel real to him. And so he'd like to reduce that anxiety. So how does he do that?
Is this anxiety specific to hospital procedures, I guess, because it's linked to what happened? I mean, the sort of this, if I understand correctly, this is what happens when you are in ITU. You have had an operation, or you might have had a cardiac arrest, and you are waking up and you are confused because you're under sedation, etc. And there you have these very vivid nightmares. They're hallucinations basically, and they I wish I knew what it felt like in first person so that I could understand completely, but it's almost like they are real things, but they're very scary, and they don't feel like dreams at all. I think in this case, so what comes to my mind is sort of systematic desensitization, which is a bit of technical jargon to say that you get used to things that scare you progressively so that eventually you're able to cope with it. And that takes a form of a hierarchy of things. So there's a few kind of procedures involved, but basically it's about doing some muscle relaxation and then being exposed progressively to what is the feared situation, perhaps initially in a visualization type of exercise where you don't actually do it, but you visualize it in your head, and then you create scenarios where it becomes more and more similar to what the actual procedure is. I think that's what works for some people that are really anxious about some hospital treatment. That's a very behavioral intervention. So you look just at the behavior, and sometimes it works very well. So I think that would be my first kind of line of approach. But obviously you need somebody that kind of walks you through these steps.
Do you access that through your GP or the IAPT service?
Yeah, I think the IAPT could. I think they could definitely do that. Yeah, if it was formulated as a problem in, I really need to address this because I have hospital admission, and I don't want to run into the same anxiety-provoking situation and become a mess. And I think it's possible. Yeah, definitely. There will be a problem if that's the problem. But yeah.
Okay, cool. Well, we've got two more sections. One's a group of questions around idiopathic SCAs, and this one's aimed at Tom, I guess. What tests, investigations do you think should be done to further look for the cause? This is obviously after the initial urgent stuff while you're in hospital.
So, yes, the cause, acutely, we go through a kind of clinical, we call it a clinical sieve. We go through the history, we go through a variety of investigations acutely, which often are an angiogram, an ultrasound of your heart. So the angiogram looks at your heart arteries and says, is it a heart attack? The ultrasound of your heart says, is it fluid around the heart? Is it a valve problem? Or is the pump poor? Is there likely a clot in the lung? We often then scan the lungs looking for clots. And we kind of go for the most common thing first. So most people, certainly in our institution, will get an angiogram because the commonest cause of a cardiac arrest in our institution is a heart attack. And we obviously need to find that and treat that straight away. And if that's not the case, then we gradually keep coming down the things that are less and less likely, which include, you know, a poor pump, fluid around the heart, a clot in the lung, and then something else going on. And we've got to be sort of quite broad in our looking for things. If we don't find anything, and of course, if you're a younger patient with no other problems, it becomes more likely that it's just a heart that's gone a bit crazy. So if it's just a heart that goes into VF in a 25-year-old man who's otherwise fit and well, then obviously our focus very much is on the heart muscle itself. And so what we would usually do to that end, after the angiogram, after all the other things that we've talked about, you would usually have an MRI of your heart. And the MRI is the best way to look at a heart muscle. And if you have got what's called a cardiomyopathy, so a heart muscle which is a bit abnormal and caused you to have your cardiac arrest, then the MRI is pretty good at finding it. However, there are still patients who will have an MRI that comes back as normal, and that you can't determine what that is. The ECG plays a role, because if your ECG is abnormal but your MRI is normal, it probably suggests that there's a problem with your heart muscle that just isn't detectable on an MRI. The other things, what I would then do is I would usually refer patients to London for a sort of more in-depth cardiomyopathic diagnosis, which usually involves genetics. We don't have a genetic service within Essex, and certainly it is even limited sometimes in London and other sort of big cities. So most of the time they will do some genetics to look for inherited problems. And the reason to do that is twofold. Number one, to try and give you a diagnosis. So you can go, you've got this mutation of this particular gene that affects your heart muscle, and that's why it happened. And of course, if you do detect that, that's incredibly helpful if you do have children as well, because then you can, if you like, risk stratify your children. If they carry that gene, they're probably at a risk. If they don't carry that gene and they're free of that gene, then probably they have the risk of cardiac arrest of the next person along down the street, and not at higher risk than they would be. So that's really about it. I think what is fair to say, and this was brought up at a meeting we had this week, is let's imagine, God forbid, someone has a cardiac arrest and, oh, Marco, sorry, there's a medical emergency in the Chinese. Give me a second.
Wow.
Indeed. Oh my goodness. Anyway, I can't really ask him the next couple of questions. I guess that's not really your cup of tea either, Marco, is it? So
Let's hope to God it's not an arrest.
Yeah.
Yeah, I hope not.
Oh, God.
No, that would be rather ironic.
Ironic. Yeah, wouldn't it?
How can I ask everyone how they're finding it, in particular if it's the first time on the call? Is it providing good information for you? I think excellent.
Hello.
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 Hello. I was going to say one question we could ask. It's Ruth Harvey. I'm actually with Simon as well. But I had a prior diagnosis of PTSD before I had a cardiac arrest. Because some people get double winners. And I just wondered, is there any link to having had PTSD before? Is there any link to having a cardiac arrest?
I mean, gut feeling is to say no, there isn't, because obviously it's more around the cardiovascular disease rather than anything else. Unless there was an underlying genetic condition. But if that's not the case, then I'm tempted to say no, definitely. I mean, we should hear from Tom, but I'd be surprised.
Thank you very much.
Look, see if there's any other PTS or psychological type questions.
Let me ask a question. My
Sure.
husband had the cardiac arrest, and he now has kind of funny flashbacks, not to the SCA, but being thrown back in time. So all of a sudden, it's like he's seeing people he knew as a child and such.
Yes, I've seen this in the chat. I mean, it's bizarre, isn't it? And it's actually probably the first time I've heard of this. But having a cardiac arrest, especially if your recovery after was a bit difficult, does funny things to memory sometimes. And not just, memory for things you did an hour ago, a day ago, a week ago, but even what we call autobiographical memory. So memory of your own life. It's not uncommon to forget kind of important things of your life, or sometimes even to relive certain events that you thought you had completely forgotten. So it can do funny things to memory, and this cannot actually change over time. So it's interesting to hear of this. It's the first time.
I've personally experienced something like that, not 70 years back because I'm not that old, but my brain or my memory works funny. I can be doing something and then all of a sudden I have some totally random memory that's got nothing to do with what I was thinking about or doing. It sort of interrupts my thought process, and I think, where the hell did that come from?
Yeah, I guess for some people that would be normal anyway, regardless of what's happened to them in their life. For some people not. But yes, it can do funny things with memory. I sometimes ask people, look, do you have, is everything okay with, when you were young and things like that? Do you remember all of this? And it's usually okay. For some people it isn't. And for some people, they sometimes realize they've forgotten things or some things have come back. Yeah, I think, we can say it can do funny things.
So,
Now you can talk.
hello. So there's no underlying reason or explanation for it. I'm 81 and I can go back, my memory flashbacks that my wife just asked the question about, to when I was, say 10, and I have recall of motor car number plates and I can recall them instantly. Now, what's that all about?
Well, if you think about how the memory is structured in the brain, so this is recorded somewhere in your brain, and it's probably not very important, but for some reason it's still there. So when we have, this is a bit of a speculation. So obviously memories are electrical activities. That's not speculation. That's actually true. So all our cognitive functioning, it's electrical activity between our neurons. So obviously this is a pattern of neurons becoming activated for whatever reason that didn't happen before. And that's where your memories are. So it could be that something has been touched because of the cardiac arrest and possibly a consequent little hypoxic involvement. Shall we say injury? I don't know circumstances, but sometimes that can happen. And so memories are these flashes of pattern of connections that are recorded somewhere deep in our brain, and they become available at one point rather than another. So that's where they come from, and why they're coming now and not before. That's a good question, but it's probably always been there, and it's a bit like been liberated now, and it comes back, whereas before it didn't. But it's also always been there, usually.
Has anyone else got any questions to ask Dr. Marco? Do you mind just for the last minute or two, Marco?
No, that's okay. As long as I can answer. I can see there was a raised hand by Simon. Is that right? No. No, sorry. Yeah, I mean, I'm happy to take.
Let me just have a little look down the queries, the chat. Someone asked, or Stephen asked, what is the IAPT referred to in regards to anxiety?
Yeah, it's improving access to psychological therapies, which is basically psychological therapies that can offer pretty much a good spectrum of therapies, such as CBT or other mainstream and evidence-based therapies. And actually, if you go to your GP, if you manage to get hold of the GP and have an appointment, but it's actually not necessary to get the GP to many of these accept self-referral. It depends on which area you are. It will have different names. So I think in Essex is Therapy for You. In Kent it's different. In Surrey it's different again. In London there's plenty. But now the other day I was counting how many of these services were available in a certain area, and there were like 7. So there's different providers, and Mind offers something as well. So if you Google, or if you want to be sure, just ask your GP, because sometimes they also have counselors associated to the clinic. But there's quite a lot of possibility to access support for mild to moderate psychological difficulties. It's just about navigating the system and sometimes having a bit of patience.
If just to follow on from what Marco just said, on our website we've got a page called Counselling, and it details all about that, how you can access the IAP. There's a page on the NHS website which allows you to put in your postcode, and it'll show you what is available in your area, and there's a link from our website to that. And you, as Marco said, you can go via your GP, or you can actually self-refer. And also, if you're within the members of the group, as you all are, SAD UK offer up to 6 free private sessions with a BACP counsellor. If you've tried all the usual routes, we all know that the mental health system is under a bit of strain. So, you know, after my cardiac arrest, my doctor suggested that I get some help from them, which is about, I think it was about a year after. But then it took 9 months to actually access that. So it was well over, or coming up to 2 years before I actually accessed it. And by I didn't actually really need it, to tell the truth. So private sessions would have probably been more relevant for me, because I would have been accessing them a lot quicker. We've gone past 8 o'clock now, Marco, so
yeah,
you're free to go unless you want to.
No, yeah, I think the medical emergency is still ongoing there. The Chinese
which
is surprising.
That's not looking
Hope
good,
everything is okay.
Yeah, although, you know, whoever it is or whatever it is, he couldn't be in a better place, because Tom was about to do a talk to a load of GPs. So.
Okay. Having said that, probably the typical GP will know 1 or 2 out of hospital cardiac arrest survivors in his professional life, maybe. I mean, if we look at the numbers, so they may not have that, but they will have the skills to resuscitate someone.
Yes, I would hope so anyway. Okay, well, I'd just like to say thank you very much, Marco. If everyone else wants to stay on and have a little informal chat for 10 or 15 minutes, I'm quite happy to do that. But just say another brilliant session, Marco. Thank you very much for your time.
Thank you. Hope that was helpful. And okay. Yes, we are working to improve outcome. So we are looking to offer something to people that are discharged from our unit. We have projects in place. So hopefully people that are coming now will get a bit of better care. I don't know what individually you have received, but we are striving to do things better and better over time. So
sorry for my little interlude. Sorry, I'm in a Chinese restaurant and unfortunately someone passed out downstairs. Anyway, not a cardiac arrest, which is good. Yes. Anyway, what was I going to say? Yeah, so just to echo what Marco just said. The other thing, Marco, which we haven't said.
Picking up where he left off, incredibly.
Well, we may well want to involve Paul and his group in some of the discussions about what our virtual care pathway looks like. So we may well, via Paul, want to liaise with you, have a little, sort of an evening when we spend an hour talking to you guys. This is what we might offer our patients. Do you like it? How would you want to tweak it?
Most definitely, yeah, we will be
in a sort of focus group way, because we think we know what you want, but you know what you want. We don't really. We just try and adapt it to reflect what you need and want. Yeah, and look, we love doing these things. You guys need better support, and we're trying to deliver that. So yeah, thanks for your time. And I think we should definitely do another meetup and a virtual world record.
Just like to say that I just said thanks to Marco, and thank you very much for your time as well, Tom. It's been brilliant as usual. Thanks very much. And then go and enjoy your Chinese now.
No, I've got to do my talk. Yeah, I've got to do a talk. Yeah. Then I've got to check my patient. Anyway,
Yeah.
right. All the best, guys. Good night.
All right.
All the best. Thank you.
Cheers.
Thank you for having
Thank
me.
you.
Bye.
Bye bye.
Bye.